Good afternoon, and welcome to the Quest Diagnostics sponsored webinar. MACRA, CMS reviews the Year 1 data. My name is Colby Dix, and I'll serve as your moderator and host today. We have a lot of material to cover in this hour, and we're very pleased to have a guest speaker from CMS with us today, Molly McHarris, to discuss the evolving state of MACRA and how it's going so far. Today's session is brought to you by Quest Diagnostics and their Quantum Practice Solutions Suite. Quest Quantum offers a complete end-to-end solution for all of your practice needs. We focus on the business side of things so that you can focus on your patients. And we have a range of technology solutions to support your practice in every way. We connect healthcare organizations, community physicians, and patients to improve access to information and insights. Our applications work harmoniously to promote physician loyalty, provider collaboration, and positive patient outcomes. And because we're backed by Quest Diagnostics, you know that you can rely on a stable and proven partner. Our network is strong, connecting over 500,000 physicians and touching the lives of over a third of all Americans every year. The confidence and reliability that comes standard with every Quest Diagnostics relationship is easy to appreciate and to benefit from. Our holistic suite covers every aspect of your patient and practice lifecycle, from appointments and reminders, documenting a patient visit, verifying insurance and processing payments, right through the integrated follow-ups via our MyQuest patient portal. If you're looking for a complete solution from a single source, we have you covered. Our electronic health record is an ONC-certified, award-winning product that works extremely well with small practices like yours. It's cloud-based with powerful mobile integration to your smartphone or iPad, allowing you to work wherever and whenever it's convenient for you. The practice management side allows your front office to work more efficiently to manage the flow of patients, keeping your practice organized and agile, linking directly to your EHR so that you can spend more time focusing on your patient and billable encounters instead of front office administration. And if you're considering an enhanced medical billing service, Quantum RCM is an outstanding revenue cycle management product as well. Few things are as time-consuming for your practice as billing and collections, so handing off the more monotonous busy work can free your staff to focus on patients instead of spreadsheets. So trust us to provide you with a solution that's up to date on the evolving changes and trends in the industry. I'd like to extend a warm welcome to our presenter today, Molly McHarris. Her bio is up on the screen now, and you can see that we're really quite lucky to have someone with such expertise available to us, and you'd be hard-pressed to find a more knowledgeable speaker on the subject at hand. And with that, I'd like to welcome Molly McHarris.
Okay, great. Thank you for that introduction, Colby, and thank you guys for being here today. Apologies for the technical difficulties. Okay, as Colby said, there's a lot of information that I want to go over with you guys, so I'm going to go ahead and jump right in. So as we've discussed, I'm going to be focusing on the quality payment program, particularly the MIPS track of the quality payment program. I'll give you guys a brief overview of what we learned from our Year 1 experiences, and then spending the majority of the time talking through our Year 3 requirements. So let's go ahead and jump right in and move to the next slide. So as folks are aware, or I hope you guys are aware, since we're now in the third year of the program, the quality payment program consists of two different tracks. So the quality payment program, what it is, it's a program that is available for clinicians. I'll go over the details of the eligible clinician population, but typically if you are a physician assistant, a nurse practitioner, or a other type of practitioner such as an occupational therapist, a physical therapist, clinical psychologist, you would typically be eligible for participation under this program, also if you bill under Medicare Part B. And so what the quality payment program is doing is we are changing the way that clinicians interact with Medicare, our healthcare system, and we are moving the needle on value, which we define as quality in care and taking into consideration the patient's experience. So to do that, there are two ways that you can participate. The first is under the MIPS track, which again I'll talk through in more detail today. The second option is participation through an advanced alternative payment model. This is where you would still be assessed on quality and cost, but there would also be risk sharing. We do ideally want to encourage as many clinicians as it makes sense to join an APM. So if you guys do have additional questions on APM participation, happy to talk through those when we get to that time. So what was life like prior to the quality payment program? So prior to the Quality Payment Program and the passage of the law MACRA, the Medicare Access and Chip Reauthorization Act, there were 3 legacy programs that clinicians had to participate under. That included the PQRS program, the Physician Quality Reporting System, which focused on quality, the Physician Value Modifier, or VM program, that focused on quality and cost, and then the Medicare EHR Incentive Program for eligible professionals, which dealt with the usage of certified EHR technology. Those 3 programs have since ended, and aspects of those programs have continued on into the MIPS program as well as into the APM side of things. So as you can see here, what we do under MIPS is we assess clinicians' performance under 4 areas. That includes quality, cost, improvement activities, and promoting interoperability. Promoting interoperability deals with the usage of certified EHR technology, and improvement activities deals with practice-level improvement that clinicians and their organizations can take. As you can see, under these 4 performance categories, each has a number or weight associated with it. All 4 of those numbers sum up to 100 points. This is important because what we do under MIPS is we assess clinicians' performance on these 4 performance categories and assign something called a final score. That final score, depending upon where it is in relation to the performance threshold, will determine whether or not a clinician receives a negative, neutral, or positive MIPS payment adjustment. So by law, the total amount of adjustments we distribute must occur in a budget-neutral manner. So what that means is that the total number of people that would be receiving the negative adjustment, the penalty, that will offset the total number of people that would be getting the positive adjustment, the bonus. And I'll be talking through this in more detail as we continue to move along. So more to come here, but the number I do want folks to remember when we think about our Year 3 requirements is the number 30. So you would want to have your final score at or above 30 points in this 3rd year. If it is below 30 points, you would be receiving a negative adjustment, which we ideally want to minimize the number of folks who would be receiving that negative adjustment. Okay, so a high-level timeline of what participation is like under the MIPS program. So for calendar year 19, this is our 3rd performance year. That is when you should be performing the quality measures and activities for your patients. You would then submit your data to us. The majority of the data submission occurs during the 1st calendar quarter. After the performance period, we then issue feedback, and then your payments become adjusted for the 3rd year in calendar year 2021. And you'll see this timeline repeat itself year after year. So you can become familiar with this timeline. The years itself will change somewhat, but the overall process of about a year performance, data submission, feedback becoming available, and then adjustments occurring, that is something that you can plan to anticipate. Okay, so let's start talking through our year 1 experience and results. So just a couple reminders. So back in our 1st year of the program, which was calendar year 17, folks may recall we had our Pick Your Pace approach. And so the Pick Your Pace approach was in response to really the overwhelming feedback we heard from stakeholders that folks weren't quite ready yet to take a deep dive into value-based care. Some of you were, but a large portion of you were not. So what we did is we structured the program in a way that you could participate in the 1st year by doing a minimal amount of reporting and performance and still avoid the negative payment adjustment. So as you can see on this slide here, the performance threshold, which in year 3 is set at 30 points, in the 1st year was set at 3 points. So that means that you could have just submitted one measure and you would have received a neutral adjustment. We were able to recently release our experience report. This came out a few weeks ago, which provides a comprehensive overview of clinicians' experience under the Quality Payment Program. A couple things that I want to highlight within this report, also in comparison to some of the experience reports we've issued under the legacy programs. So this report is only about 20 to 30 pages long, whereas the reports we issued under the legacy programs were really lengthy, around 100 to 200 pages. And what we heard from all of you was that while that detail was useful, it was almost overwhelming, the amount of information we contained in there. So we've really tried to work through using our human-centered design techniques and using user experience testing to really ensure that the data points we're providing are those that are most meaningful, particularly the data points related to participation, reporting options, performance categories, and final scoring payment adjustment. So what are some of the key findings? So from our first year's experience, we found that a little over 1 million clinicians were eligible. Of those that were eligible, 95% participated and were able to avoid a negative payment adjustment, with 93% of clinicians being able to earn a positive payment adjustment. So again, remember, in the first year, the performance threshold was set at a really low level. It was set at 3 points. So we're really pleased to see that the overwhelming majority of clinicians were able to take advantage of our Pick Your Pace approach and to participate within the program and still avoid that negative payment adjustment. So how do people participate? Of the over around 1 million clinicians, we found that the overwhelming majority of folks participated as a group. So as I'll talk about in a few upcoming slides here, under MIPS you can participate either as an individual or as part of a group, or we've newly added, beginning in the second year of the program, the ability to participate as a virtual group. What we found is that the overwhelming majority did decide to participate as a group. It is not required that you participate as a group. It is an option available to you. But again, we found that a large majority of practices found that the group reporting option seemed to have a higher burden relief than some of our other options available. For some information on the advanced APM track of the Quality Payment Program, so we had more than 99,000 clinicians become qualifying APM participants, which far exceeded our estimates. So what that means, if you become a QP, that means that you are exempt from the MIPS program and you are able to receive a 5% lump sum incentive. So we're really happy that over 99,000 clinicians were able to achieve that status in the first year. And then for how did people report? So how many actually partook in our Pick Your Pace approach of reporting for less than 90 days versus those that did up to 12 months versus the full 12 months? So what we found from our results here is that the majority chose to participate for the full 12 months or greater than the 90-day period. So as you can see on the slide here, only around, it looks like, less than 1 percentage point of clinicians actually participated for less than the 90-day period. We saw that the overwhelming majority of clinicians participated really for the 12-month period, but with a portion participating for a little bit less than 12 months, but still greater than 90 days. Again, we're really happy to see this. We do believe that, particularly for the quality performance category, reporting for a 12-month period will provide greater outcomes, particularly based off of certain outcome measures. And just some additional detail on the time frames of reporting for small and rural practices. So we also found that small and rural practices chose to participate for closer to the 12-month, greater than 90-day period. There were a few smalls and rurals that participated for less than 90 days compared to other clinicians, but again, the majority participated up to the full 12 months. And for where did our final scores and payment adjustments hit? So this becomes important again when you think about the MIPS program and how it must maintain its budget neutrality. So we again had 95% of clinicians that were receiving a neutral or positive MIPS adjustment, with 93% receiving a positive adjustment. We also had around 71% of clinicians able to receive the exceptional performer bonus. So as many of you know, the total amount of payment adjustments we were able to distribute in this first year were lower than what we had initially anticipated. When you actually see these data results and you see that the total number of people that did participate was at 95%, it makes a little bit more sense on why the total amount of money we could distribute was lower. Again, that's due to budget neutrality. So as you can see on the bottom right-hand corner of the slide, when you look at the positive with additional adjustment, our maximum payment adjustment we were able to distribute for those clinicians receiving the exceptional performer bonus was 1.88%. Okay, great. And so that summarized everything for the year one results. There's a lot more information that is available within that report. So again, I do highly encourage everyone to take a look at that if you haven't had a chance to do so as of yet. So let's dig into the year three participation requirements. So I'm going to focus on really what has changed from year two to year three. So what's changed beginning in the third year is we have expanded those types of clinicians who can be eligible. So in prior years, it was simply physicians, PAs, NPs, CMSs, and CRNAs. We've also, beginning in the third year, expanded out those that are eligible to include psychologists, PTs, OTs, audiologists, speech-language pathologists, dietitians, and nutritional professionals. Some of the other changes that we've made are related to our exclusions. So we do still have our exclusions from MIPS, where if you become newly enrolled during the performance period, you are excluded. Also, if you significantly participate in advanced APM, so if you become a QP, you are excluded. And then we have our low volume threshold exclusion, which we tend to spend a lot of time talking about because this one has been modified from the first year to the second year to the third year. So the way that it works in the third year of the program is that you are considered to be a MIPS eligible clinician if you bill above 3 criteria. And those criteria are billing more than $90,000 annually, providing more than 200 services, and providing care to more than 200 beneficiaries. So one of the common questions we get asked is, what is the difference between a patient and a service? So between those last two. So when you think about the difference between a patient and a service, think about a scenario where, as a clinician, you have one patient, but that patient may come in to see you 5 or 6 times during the year. So that one patient would count as a 1 towards the patient count, but the 5 or 6 separate times that you see that patient would count as the 5 or 6 towards your services count. So it's very common that your services count could be slightly higher than your patient count. So one of the other changes that we made is we modified the way that the low volume threshold worked to account for instances where you may meet 1 or 2 of those criteria, but not all 3. So if you meet 1 or 2 of those criteria, but not all 3, you do have the option to opt in and to be considered a MIPS eligible clinician. If you do not meet any of those 3 criteria, you would not be considered a MIPS eligible clinician, and you would not be eligible to receive the payment adjustments, either the positive or the negative. So for example, if you are a clinician, and let's say you bill $100,000 annually, you provide 400 services, but you only see 100 patients. So you would meet 2 of the low volume threshold criteria, but not all 3. So what that means is that you would be eligible to opt into the program. If you choose to opt in, That choice is irrevocable, meaning that once you decide to opt in, that decision must be maintained. We are still working on the design of the opt-in process, so stay tuned for more information on exactly how you will be providing that decision to us in the coming weeks and months. In the interim, though, you can go to our website, qpp.cms.gov, and go to our lookup tool and provide your NPI, and it will let you know whether or not you are a MIPS eligible clinician, if you have any special statuses. A special status typically provides certain types of scoring relief. Typically it means that you would have to do a little bit less than clinicians who may not have a special status. And the lookup tool also will provide information on whether or not you may be an opt-in eligible clinician. So one of the things that commonly happens when you go to the lookup tool is that you could be associated with multiple practices. So when you think about participating under the MIPS program, it's based off of a unique TIN NPI combination. So your NPI being your national provider identifier, but your TIN being your practice identifier. So if you work at multiple different locations or different organizations, you could be associated with multiple practices. And so we would assess your eligibility under each of those unique TIN NPI combinations. So it is possible that you could be eligible under one organization, but excluded under the other. So those are the eligibility basics. So hopefully folks have a pretty clear understanding of what you need to do to be considered eligible for the program and where you can go to find that information. So now I want to start talking through the 4 MIPS performance categories. So first, focusing on quality. We do still have for quality that it will contribute 45 points towards your final score. The basic criteria still are 6 measures, where 1 would need to be an outcome measure. If one of those outcome measures is not available, you would need to select another high priority measure, such as outcome, patient experience, patient safety, efficiency, appropriate use, care coordination, or be newly added for this 3rd year opioid-related measures as high priority measures. So some of the other basics for the quality performance category. So as a reminder, for each measure, you can typically earn between 1 and 10 points. Some measures have a cap on them if they are considered to be topped out. Other measures may have a higher floor. So if you, for example, fail data completeness and you are a small practice, you would get 3 points. If you are any other type of practice, you would only get 1 point. We also do have bonus points available, and you can earn these on a per measure basis. So you can get bonus points for reporting on additional outcome or patient experience measures, for reporting on additional high priority measures, and also for reporting on measures in an end-to-end fashion using your certified EHR technology. We also have bonus points available for small practices. So if you are considered to be a small practice, so when you go to our NPI lookup tool, if you have the small practice special status designation, if you submit at least 1 measure for the quality performance category, you would be eligible to receive that small practice bonus. We also still have our data completeness thresholds for 2019 set at 60%. So data completeness really deals with the reporting of the measure. So what we're looking to see here is that you have reported that you could have done a quality action for at least 60% of your patients. I do want to note that under the MIPS program, we are looking for these actions to occur for all of your patients, not just your Medicare patients. So it should be for any of your patients that fall into the denominator of the measure. So in cost, in the 3rd year of the program, this will contribute 15 points towards your final score. As a reminder, there is no separate reporting requirement for cost measurement. We calculate this completely based off of your claims data. We will measure you on, or we will attempt to measure you on a Medicare spending per beneficiary measure, as well as a total per capita cost measure, and 8 episode-based measures. So again, we will attempt to calculate your performance for all of these measures, the MSPB as well as the TPCC measure and these 8 episodes. If we are unable to calculate your performance on all of these measures, we will base your performance on the measures we are able to calculate. So for example, we can only calculate the MSPB measure and 1 of the episode measures. Then your performance would be based off of just that subset. If we are unable to calculate any of these measures for you, then the cost performance category, those 15 points, would get redistributed to quality, with quality contributing for 60 points in this 3rd year, again, if we are unable to calculate costs for you. So for improvement activities in year 3, we didn't make too many changes here. It still contributes 15 points towards your final score. There are over 100 activities that you can select from. Each activity has a weighting of either high or medium. As a reminder, the majority of clinicians will need to have their improvement activities add up to 40 points. So as you can see on the slide here, the high weighted activities count for 20 points, the medium weighted activities count for 10 points. So you can choose any combination of medium or high weighted activities to get at those 40 points. We just need to receive a simple attestation that yes, the activity occurred for a minimum of a 90-day period. But once you start actually looking at the improvement activities, you'll find that the majority of these can actually occur for longer than a 90-day period. I also do want to note that if you have a special status, such as being a small practice, being a non-patient-facing clinician, etc., your activities are double weighted. So that means that if you are one of those types of clinicians, you would only need to do, for example, 1 high-weighted activity. So again, as a reminder, promoting interoperability deals with the usage of certified EHR technology, and we made some fairly significant changes to promoting interoperability as we move from year 2 to year 3. We actually completely overhauled this performance category. So in the 3rd year, promoting interoperability still counts for 25 points towards your final score. You must use 2015 edition certified EHR technology though. So in prior years, you have the option of using a combination of 2014 and 2015 edition cert. Beginning in this 3rd year, clinicians do need to be on 2015 edition cert. We also have reworked this performance category to have performance-based scoring at the individual measure level, which covers 4 objectives: e-prescribing, health information exchange, provider-to-patient exchange, and public health and clinical data exchange. So as you can see on this slide here, there are 4 objectives with a number of measures that are available under each of these. There are also a certain number of points that are associated with each of these measures and objectives. So to earn a score for the Promoting Interoperability Performance category, what you must do is 1, be using 2015 edition cert for a 90-day performance period. Then there are a series of attestations you must confirm. The first deals with the prevention of information blocking, so attesting that you have not information blocked. Attesting to the ONC direct review attestation, as well as the security risk analysis measure. Then you would need to report the required measures and objectives, and or if you have any exclusions for any of those measures or objectives, you would need to claim those. In instances where an exclusion is claimed from a given measure, those points are redistributed to the other measures. We do still have our reweighting of the Promoting Interoperability Performance category for certain scenarios. So we understand that a number of clinicians have an inability to complete the Promoting Interoperability Performance category due to a variety of reasons. So in those instances, the 25 points that are currently allocated for promoting interoperability will get redistributed to the quality performance category, with quality contributing 70 points towards your final score instead of the current 45 points. So these are based off of either automatic reweighting or application-based reweighting. So if you are a clinician type other than a physician, you would receive automatic reweighting. The same if you are a non-patient facing clinician, a hospital-based clinician, or an ASC-based clinician. So those are automatic. You would automatically get PI redistributed to quality. If, however, you submit to us promoting interoperability performance category data, then we would take that to mean that you no longer want to have promoting interoperability reweighted and you want to submit data to us. So just something to keep in mind there. Then we also have application-based reweighting, and this accounts for other types of instances, such as extreme and uncontrollable circumstances, if you are part of a small practice, insufficient internet connectivity, etc. We anticipate that the application-based reweighting process will open up sometime this summer and will be available to the end of the performance period, so the end of this calendar year. Okay. Now that I've talked through the 4 performance categories, I did want to briefly touch on some of the additional flexibilities and support that we have for our small and rural practices. One of the things that we have taken into consideration since the beginning of the quality payment program is the role and intricacies that small practices and rural practices face. We do understand that there are additional challenges that face small and rural practices that other cohorts of clinicians may not have impacting them in the same manner. So some of the things that we've done you can see on this slide here, and I've already touched on a number of them, include continuing to maintain the small practice bonus, which previously was at the final score and now it's part of the quality performance category. We do still have higher points that are available for small practices that don't meet data completeness. We also still have our flexibility for smalls as well as rural, that their improvement activities are reweighted. And then we also, of course, have for the promoting interoperability performance category, if you are a small practice, that through that application-based reweighting approach I just described, you can have promoting interoperability, those points reweighted to quality. I also do want to emphasize again that we have our no-cost customized technical assistance under our small, underserved, and rural support initiative. I highly encourage any and all of you that are in a small, underserved, or medically underserved or rural region to take advantage of this free technical support. We have folks who will actually come to your office and help you with establishing your workflow, rather of participation within the quality payment program. We do also have technical assistance to other groups, but we have this dedicated technical assistance for the small, medically underserved, and rural. And okay, so that covers everything for MIPS. So let me just briefly talk through some items related to alternative payment models. So for advanced APMs, they are a subset of alternative payment models. So what is an APM? It's a payment approach that provides added incentives to clinicians to provide high quality and cost-efficient care, which typically involves risk sharing. It can apply to either a specific condition, a care episode, or a population. So you'll notice that we have some APMs that are regional or locality-based, whereas others that are specialty or care episode-based. There are significant opportunities for eligible clinicians who are not ready to participate in an advanced APM, such as the MIPS APM. So clinicians and practices, they can receive greater rewards for taking on some additional risk-related patient outcomes. So not only for participation in an advanced APM would you be eligible to potentially receive that 5% lump sum bonus, but you also can receive APM-specific rewards as part of your risk sharing. So there's typically a lot of additional financial incentive for joining an APM well above and beyond that 5% lump sum incentive that we have here. So to be an advanced APM, there are 3 criteria that must be met. The first is that the APM itself must require the usage of certified EHR technology. The second is that the quality measures must be comparable to those measures used under the MIPS quality performance category. And then third, the APM must either be a medical home model expanded under CMS Innovation Center Authority, or what is much more common, requires participants to bear a more than nominal amount of financial risk. Okay, moving on to wrap up what we have for the quality payment program here today. So again, we covered a high-level overview of our year one results for the quality payment program. We also talked through, for MIPS, our year three eligibility requirements and our performance category requirements. And we also talked through some highlights related to the advanced APM track under the quality payment program. So just a couple of sets of resources I want to make sure that you all are tracking to. We have a number of resources on our website at qpp.cms.gov. We're actually continuing to add new information there all the time. So on the slide here, these are a number of our tools that we have available. I already went over our lookup tool, which is where you have the ability to enter your NPI and it will reflect back to you whether or not you are eligible to participate. We also have our shopping cart Explore Measure tool, which will allow you to sort and filter per performance category the measures and activities you would want to select from. We also have our resource library, our webinar library, and I also do want to highly encourage those of you who have not yet signed up for a listserv to sign up for a listserv. We share a lot of information on that all the time. So just to highlight again some of our free technical assistance, which is available to all clinicians. We have our CERS dedicated technical assistance, our Quinn QIO network. We also have our service center, which is our help desk. And we also, of course, have the Transforming Clinical Practice Initiative, which is really leveraging lessons learned by high-performing practices who are joining APM. So again, highly encourage all of you to take advantage of as many of these resources as you can as you participate in the quality payment program. So at this point, I'll turn it back over to Colby.
Molly, thank you so very much for the presentation here today. Obviously, quite a lot of information provided there, some great insights to be sure. We would like to open it up for questions now from our live audience as we move into this Q&A section. I do have a couple of them here, Molly, if you'll indulge me. The first that I can paraphrase for you, how likely is it that the Promoting Interoperability Performance category would have changes next year to improve HIE, such as the published list of EC's email addresses, or requiring EMRs to be part of the Direct Trust Network?
Yeah, thanks, Colby. That's a great question, and I definitely can understand that folks want to get a sense of not only what the requirements will be for this third year, but also how things may be changing in the future years. Unfortunately, I can't comment on what may be changing within the future, so I apologize for that. I can't really say what will or will not be being modified here. I do encourage those of you who are interested in this question, though, to take a look at our proposed rule. When our proposed rule comes out for our intended or proposed changes, we will have a 60-day comment period associated with that rule. So again, just another reminder why, if you haven't already signed up for our listserv, to please do so, since that will provide information on when that rule comes out, as well as available resources such as additional webinars, educational sessions, where we can talk through that question in more detail.
Yes, thanks, Molly. And as well, I do absolutely encourage everyone to go ahead and sign up for that listserv. But with those of you who are on our mailing list with Quest Diagnostics, when we do have that finalized information from CMS, we tend to try to reach out and have someone such as Molly come and explain the changes as they occur as we move forward. So stay tuned to your inbox for that as well. As changes as they are codified, we do try to communicate them as best we can. Question number 2 for Molly. On the experience report for 2017, ECs that earned the full positive payment adjustment only received 1.88%. What does the positive payment adjustment look like for 2018? Once again, another sort of crystal ball question. I know it's maybe not, you don't have all the data yet, but if you have any insight into that, we'd appreciate it.
Yeah, another great question. I'll just apologize in advance. My crystal ball is not working too well today, so I can't really theorize on what things will look like. As folks know, we just earlier this month closed our data submission period for the 2018 year. So we are in the process of working through all of that data, scoring that data, working internally on calculating everyone's performance category scores, establishing folks' final scores, working with our Office of the Actuary to establish budget neutrality. So, long way of saying I don't have those data results available as of yet, but I do want to encourage those of you who did submit data in the second year, which hopefully is everyone, that we have been able to release some preliminary feedback, which is available to you. So we do, again, have some preliminary feedback that's available within our portal right now, within the qpp.cms.gov website when you go and log in. So I would highly encourage folks to take a look at that. When the official final feedback is released around the beginning of July, we'll be able to have a little bit more details on what the payment adjustment percentages look like and what the distribution is. But at this point, unfortunately, we don't have that information available, but we anticipate it will be available in the near future, both as part of our Year 2 experience report, and to the extent we can share any of those results prior to the release of the formal experience report, we definitely will do so.
I have a bit of a two-parter here. The first part of the question, is there any benefit to reporting for an individual if they're not eligible? And the second part of that, can we start reporting in 2020 if we haven't done so prior? So really a question as far as the benefits of reporting for individuals that don't meet the threshold at this time.
Sure. So if you are not considered to be a MIPS eligible clinician now, you definitely still can participate within the program. I would encourage those of you who anticipate you may be eligible in the future to go ahead and start participating now. Some of the benefits of participating without actually being a MIPS eligible clinician are you get to try out, you get to kind of train yourself in the program before you're actually being assessed for performance with payment impact. Also, as part of that kind of testing that you'll get to do with us, we will be able to receive or provide to you feedback on how you performed. So again, if you're not a MIPS eligible clinician, you would not be eligible to receive any of the payment adjustments, so any of the money associated, whether it would be positive or negative. But if you do decide to participate, you would still be eligible to receive feedback. So again, that can help you as you anticipate that you may be eligible for participation in a future year. I hope that helps.
Yeah, I think that sounds very helpful. Thank you. Another question here. Will there be an exclusion introduced for the 2019 year that allows ECs to be excluded from the Public Health and Clinical Data Registry reporting option? They elaborate a bit. If the ECs have to spend money in order to meet the measure, for example, an EC has to pay $475 per year per physician to count that they are in active engagement with a public health agency, that sort of thing. So that's relating, once again, to the ECs having to spend money in order to meet the measure, and will there be any exclusions surrounding that?
Yeah, great question. And I will say this is a fairly common question we've received. I apologize on this one again as well. So for this one, we do have a number of established exclusions. We did finalize the requirements for 2019 in last year's rulemaking. So I would highly encourage folks to take a look at the Promoting Interoperability Specification Sheets and Fact Sheets for more details on exclusions and hardships. Those are all available on our qpp.cms.gov website. Any additional exclusions that would be granted that aren't contained within those measure specification fact sheets would be a part of rulemaking. And again, I apologize, I can't comment on what would be part of rulemaking versus not. So I'll just have to leave it at that. Thank you.
Very good. Another question here. This one, I think we have enough to clarify. The opt-in option, if selected, is that applicable for practice year 2019, just 1 year at a time, or does it essentially enroll you for moving ahead for future years as well? Or do you have to every year opt in?
Sure, great question. So it would be an annual process. So also it's a great reminder that when you think about participation in the quality payment program, it is annual in nature. So while uncommon, it could be possible that you could be eligible for year 1, and then you could be excluded for year 2, and then you could be eligible again for year 3. So it definitely is possible that your eligibility status, your special statuses, and your performance really could change. It's a little bit more, probably a more common scenario would be if you are changing practices from 1 year to the next, and if for whatever reason your Medicare patient volume modifies, either significantly increases or significantly decreases, that could impact your eligibility. But yes, overall, your participation in the program, and so your choice to either opt in to be a MIPS eligible clinician or to not opt in to be a MIPS eligible clinician, that is an annual choice that would occur.
All right, that wraps it up for the questions that we have here in the Q&A section. I apologize. One more did just come in at the very end here. Let me bring that one up. We have this is a clarification. Did you state that if you opt in, you would not be subject to negative payment adjustments, only feedback? Please feel free, Molly, to answer that for me.
Yeah, great clarifying question. So no, that's not accurate. So if you do opt in to be a MIPS eligible clinician, you would be, so essentially you become a MIPS eligible clinician and you get everything that comes with that, which means that you would be potentially eligible to receive a positive adjustment. It also means that you could, if you don't have in the third year your final score of 30 points, that you could get a negative payment adjustment. So when you do opt in, it means that you are saying to us, CMS, yes, I want to be a MIPS eligible clinician, and everything that comes with that. I hope that helps clarify, but if there's additional questions on that nuance, please ask.
I think I'll try to both answer and help for one more point of clarification. So as we had a couple of overlapping questions here and just want to be crystal on it if possible. The earlier question towards, is there any benefit to reporting for an individual if they're not eligible? And you answered in saying that the benefit then, of course, is learning some of the system and getting some of the feedback. Now, there's a difference there between the opt-in versus just enrolling as a non-eligible physician, correct? I just want to make sure that there's a difference here, that the nuance is clear.
Oh, yes. Yeah, great clarifying question. Actually, if we go back to, so if you are excluded but you want to participate in the MIPS program, and so this could be that you are excluded because maybe you only meet 1 or 2 of the low volume threshold criteria. It could also be that you are not one of our MIPS eligible clinician types. So for whatever reason, if you are excluded, you generally have 2 options for participation. And the 2 options hinge upon whether or not ultimately you are considered to be a MIPS eligible clinician. So the volunteering option is that you are not a MIPS eligible clinician. You just decide to voluntarily participate within the program, report on the 4 performance categories, submit your performance data to us, and you'll get your feedback. And you can do that either as an individual or as part of a group. The second option, which we've newly added for the third year, only applies for clinicians who meet 1 or 2 of those low volume threshold elements, but not all 3, and they choose to opt into the program. And so if you opt in, then you would be considered a MIPS eligible clinician, and you would be subject to all of the MIPS performance requirements, including the MIPS payment adjustment, positive or negative. Does that help a little bit?
I think it does. Thank you for returning to this slide. I remembered it was here, but didn't know exactly where to jump to either. So I think that helps with the overall clarification on those last couple of questions. Thank you. All right, then. At this time, I am not seeing further questions in the Q&A. So in respecting everyone else's time here today who did join us for this lunch session, I do appreciate it. Thank you all for coming. If you have more questions about the Quantum Healthcare IT portfolio, please feel free to call or email using the contact information on the screen. If you have other questions for Molly or CMS, you can direct them most directly, certainly, through the CMS website. Once again, we do thank you all for your attendance today, and a special thanks to CMS, to Molly, and of course to Quest Diagnostics for sponsoring the event. Do keep an eye on your email inbox for additional seminars covering related issues in the near future. This will conclude today's presentation. We thank you.